which is available. But since this falls under the category of difficult airway, I would like to highlight some of the incidents in difficult airway, like what is the unexpected difficult backmask ventilation incidents in all over the world? It's almost close to about 7%. That's been in 2013. That's the latest, which I could find. But this doesn't translate directly into incidents of difficult direct laryngoscopy or difficult direct laryngoscopic aided intubation, which is in the range of 0.06% to 3%. And difficult intubation using direct laryngoscopy is only about 0.25%. But most of them are anticipated, of which the unanticipated difficult intubation is quite less, but 0.03%. We are talking about a very small number which has been assessed. And the incidence actually goes up with decreasing age if the patient is, or the child is less than 1 year of age. Now, of all patients that have been registered until 2016 in the pediatric difficult intubation registry in US, and only very few states in US, about 1,018 patients at that point, the failed intubation happened in these 1,018 patients, about 2%. That's almost close to 22 patients. But there were complications happening in about 200 patients. That's almost 20% of that. And of the complications, about 2% had cardiac arrest, which could not be revived. That's almost close to about 4 patients. Even though it's small numbers, but I think it makes a significance when it comes to the rarity of the presentation. Now, I'm not able to see my headings. Why is this coming up like that? Okay, doesn't matter. Now, I'm not going to talk about what's the airway injury above the oral cavity that's in the nose or the nasopharynx, because if it is not associated with any injury down into the laryngopharynx or the mid-trachea or in the lower trachea, it actually doesn't involve much in your airway management or intubation or backmask ventilation. But when there is an accident or injury that's happening that involves the laryngotracheal region, even though the incidence is quite less and it's rare, and most of the etiologies are because of blunt trauma, meaning the road traffic accidents accounting for most of them, and penetrating injuries, because in my part of the world where I'm working now, it's quite a peaceful country, and so we don't get any penetrating injuries as you see in other part of the Middle East, like going to the Lebanon, Syria areas or something like that. But they usually falls under 5 groups. The minor of them, the group 1, which might be having some minor endolaryngeal hematoma or some lacerations. But on the other extreme, we have the group 5, where you can really have a laryngotracheal separation. And so the management of these scenarios are totally different. These patients might be presenting initially, might be asymptomatic, or might have some mild dyspnea, dysphonia, or some anterior neck pain. But over a period of time, when the tissue edema builds up, the patient can deteriorate, having debilitating stridor, and might end up with respiratory compromise. Now, when it comes, because I made a statement earlier that most of the catastrophes could be because of an inadequate or improper assessment. So when it comes to assessment of the airways for difficult intubation or even backmask ventilation in children, almost all the parameters that you use in an adult patient, like the Mallampati, modified Mallampatis, or those measurements that you make at the thyromental distance or the Mendenhall distance and interincisor distance, all those things, it's not been validated in children, but it doesn't mean that you have to disregard all these parameters. They are useful provided the child whom you're treating is cooperative and is able to give you the measurements possible, and also to open the mouth, and then you will be able to examine all these things. But what's more important is that the history that you get from the parents, and especially about the treatment history, and especially about anesthetic history and surgical history, whether he has had any difficulty in the airway management. If possible, review the medical records, which may not be possible in India because most of the children, they get treated in different hospitals with different doctors. But if it's possible in your institute, please review the medical records, because all these things are very important. You get very valuable information from them. And the most important thing is examination at that particular point. Because you see, a normal child, a child who had been normal earlier, even the medical records might have a very difficult airway, because I told you a traumatized pediatric airway qualifies to be called as a difficult airway. So if the child is cooperative, definitely you can go for all these myelopathy classifications and all the measurements that you can make right from the thyrometal distance or the neck size and the mobility of the neck or the incisor distance and all these things, you can do that. But when you examine the child at that particular point, and if you have received any information from the history or from the parents that the child is syndromic, or you feel that the child is syndromic on examination at the point, please focus your attention on some of those points which are very pertinent for that particular syndrome, maybe a micrognathia, immobility of the neck, cervical instability, macroglacia, or midfacial hypoplasia or microstomia, and all these things. You should be aware of it. And this you get either from the history or from the medical records or examining at that particular point of time. Now, why does the pediatric airway qualify to be called as unique and many times challenging? His most often is basically because of the normal anatomical factors. You can see here the child has got a relatively larger head in comparison to the adult, and he's got a larger occiput. And the angle between the occiput and the shoulder is less in children. And so what happens is that the child, again, when you look at the anatomical aspects, he has got a relatively larger tongue, which would compromise the retroglossal space. And when the child is put supine, this will compromise the retropharyngeal and also the retrolaryngeal space. The children, they have a larger epiglottis, which is folded upon itself, and it's quite rigid. So many times you will find it difficult to manipulate the epiglottis by placing your laryngoscope blade here. You will have to get below the epiglottis to see the glottis. And when it comes to the glottis, in a supine child, we'll see in adults, it's almost perpendicularly placed, but in a child, it's obliquely placed. And what's more important is the larynx, which is cephalad, placed more cephalad and more anterior, which makes it more difficult to access. And we'll come to discuss later is something regarding the trachea. The trachea in children, like all other aspects like the chest or other aspects, is quite pliable and less rigid. So it makes that even the slightest pressure on the trachea, you will compress that, the anterior and the posterior wall together. And then you will bypass, in fact, the larynx into the esophagus or even into the cervical spine. And what's more important now, the changing trend is that even though the larynx of the children, they appear like a funnel rather than the cylinder in the adult, which makes the cricoid the narrowest part. There's a change in trend that's happening nowadays, and there's a recommendation that's happening not to use an uncuffed tube which fits in the cricoid region and allows some leak, but instead use a smaller endotracheal tube, a cuffed endotracheal tube, to intubate these children and then place the cuff in the mid-trachea or on the lower mid-trachea. Now, if you put such children, especially an infant, on a flat bed in the OT table, you can see that even that position itself will compromise the retropharyngeal space and the retroglossal space, leading to difficult backmask ventilation and even direct laryngoscopy and intubation. A small trick by placing a shoulder bag or a small sheet folded beneath the shoulder itself will relieve this obstruction in the retroglossal space and the retropharyngeal space, and you will be able to ventilate these patients by a backmask device, and you will be able to do a direct laryngoscopy and also an intubation. This applies in older children as well. If you put an older child, even though he is developing and his angle has increased between the occiput and the shoulder, but still you can see that the oral, the pharyngeal, and the tracheal axes are quite divergent. But placing a small folded towel beneath the occiput, not beneath the shoulder, in these older children will bring the tracheal and the pharyngeal planes almost aligned. But still the oral plane is divergent. A slight tilt at the atlanto-occipital joint, that is, means you extend the neck over the neck, the head over the neck at the atlanto-occipital joint, brings the oral, the tracheal, and the pharyngeal axis in line. And then you will be able to use a backmask device or even an direct laryngoscopy and intubate these patients. Now, what is so special about the upper airway trauma? First of all, it is rare, but even if it is rare, it doesn't usually happen in isolation. It's usually associated with other injuries, usually bony injuries of the oropharyngeal box, as they call it, cervical spine, the maxilla, the mandible, or it could be associated with the lower respiratory tract into the mid trachea or the lower trachea, and it might involve the other areas or other organs of the lung, the heart. Now, an airway trauma by itself will make an otherwise easy pediatric airway into a difficult one, basically because of the edema, the bleeding, and the clots, and also the injury, the tissue injury, and some loose bodies like the teeth or the loose tooth that might have fallen into the larynx. It might be associated, as I told you, might be associated with the mid or lower laryngeal injuries, and there might be gross surgical emphysema when it involves the lower airways. And this all will lead to severe respiratory compromise resulting in hypoxia. And this hypoxia by itself, and also by involvement of the other organs, maybe vascular structures, bleeding, the patient might be hypotensive. So you get a patient who is almost compromised, and then you have to manage the airway in them. So after the assessment, when you're planning now towards the execution of your airway management, you should have some answers for some of these questions. Does the patient at hand have a potential difficult airway? By your assessment, going through your history, your examination, you should have an answer for that. Will it be difficult to maintain a bag mask device to ventilate this patient? If so, whether you will require any other adjuncts to ventilate them? Or will it be possible to do a direct laryngoscopy and visualize the airway? If not, do you need an indirect laryngoscopy? And in that case, do you have your airway cart ready and it is available on hand? If you have a failure in bag mask ventilation, what will you do? Can you use a supraglottic airway device? Is it available? Or there is a contraindication for using supraglottic airway device in this particular patient? And if all these things fail, have help immediately at hand. That means you should have somebody who can help you to get a surgical airway, or you should have experienced anesthesia colleagues and assistants readily available on site. You might be having different algorithms, your institutional algorithm, or you might get different algorithms from the internet now, and you might be having for the suspected difficult intubation or unexpected difficult intubation in children. And with all these things in hand, you still be having your airway devices, and you should check what all is available, and then you should check what all airway devices for visualization is available within your airway disease in an airway difficult airway cart. It's not enough that you have an algorithm that is put up by your anesthesia machine. You should know what are the equipments that is available for you to use and which are the working ones. And with this information, you will have to make a plan. You have to have a plan A, and if the plan A fails, you will have a plan B. And if the plan B fails, you will have a plan C. At least 3 plans should be available when you're trying to deal with a difficult pediatric airway. Before that, when you've already reviewed the patient's history and then you've investigated the patients, it's a must for all anesthesiologists to review the radiological images. I'm not talking about the report. You should review the images by yourself, especially the CT scan images. And then you should have a pediatric ENT surgeon who can help you to get immediately in short period of time a surgical airway before everything goes out of your hand. Now, when you have made a plan, please discuss this plan with all the stakeholders, including the parents of the child, your ENT surgeon, and all your anesthesia colleagues who are going to help you. And you recheck your difficult airway cart and all other necessary equipments. And most of the time, these patients, your inhalation anesthetics will not work. So you will have to prepare for intravenous anesthetic agents and always prepare for the extremes of it. You should have your rescue medications also being at hand. Now, when it comes to execution of the things, you know that you will have to position the patient properly. And then I'm not going through the details of it, but it matters. Like you see in an infant, you might you will have to have a shoulder roll and as well as a headrest. And that might be different in an older child. Whatever it is, you should have a proper sniffing position attained either in a child, an infant, or in an adult, in an older child, so that you will be able to bag mask ventilate this patient and also do a direct laryngoscopy. Now, what are some of the practical aspects of managing the airway? Now, if you're sure and if you have a plan now in place and now you're going to execute the plan, have a look at the oral cavity and the oropharynx and the laryngopharynx. And if you made it there or clear without any foreign body, plan for an endotracheal tube intubation through the oral route. Please avoid a nasal route of intubation if you don't have a fiber optic guided placement of the endotracheal tube, and unless otherwise you have excluded base of skull injuries and other tissue injuries close by in the close by areas. What I would suggest is that if you expect that you're going to take a longer time for intubation and you're going to use more attempts for intubation, I prefer and I use always insufflate the oropharynx close to the laryngeal inlet using a 6 French suction catheter placed through the angle of the mouth or to the nose, and insufflate oxygen at that very, even if the child is breathing. And then if the child allows, I would like to have a look, an awake inspection of the laryngopharynx before I anesthetize this patient. And if I feel, and if everybody for that matter, it's not only me, if they feel that the airway can be difficult in managing, maintain the spontaneous, don't do anything that stops the spontaneous breathing in this patient. If you have a direct laryngoscope available to you, use that as the very, very, very beginning. Don't try to use it when your normal laryngoscopy, indirect laryngoscopy fails. And what I would suggest is to use a smaller cuffed endotracheal tubes for intubation rather than a non-cuffed intubation tube. And then you feel that the patient, there's a lot of leak happening, and then you will have to change the tube again. I would prefer to use a CMAC device for intubating, especially infants and also in older children, because it gives me the flexibility to use the handheld device as well as the fiber optic the intubating laryngoscope, bronchoscope for usage in these patients. But if I see that the child has got a very anterior and a cephaloid larynx, I would use a glide scope along with the intubating stillet that comes along with the glide scope. Many a times when I have to use a nasal intubation, I told earlier, I would never use a nasal intubation in traumatized airway without a fiber optic guidance. So I use a hybrid technique of both the indirect laryngoscopy and the fiber optic bronchoscopy. Of course, the thing is that you should have 2 operators for it. And it helps you to prevent injuries, and it gets you into the airway quite quicker. But if all these things fail, if you have this sort of an algorithm that is being put up there, which asks you to try for a cricothyrotomy first, I would suggest never, ever go for a cannula cricothyrotomy in an infant or in a small child. You will get into problems. I will discuss it later. Immediately, if you are in problem and you feel that you cannot intubate and the child saturation is coming down, please call for help from the surgeon. The ENT surgeon can get you a surgical airway by a surgical tracheostomy. And there are specifications for the surgical tracheostomy as well, what type of a tracheostomy you should be doing in these patients. Now, what is safer? The safest one is a surgical tracheostomy in these scenarios. Never attempt a stab or a cannula cricothyrotomy in children. I'll tell you the reasons later. If you are experienced enough in a needle cricothyrotomy, you might try it, because I told you earlier, because of the pliability of the pediatric airway, and it's quite less rigid. The moment you try to puncture the cricothyroid, first of all, the cricothyroid membrane is very difficult to find in a pediatric patient because it's quite cephaloid, and then you will not be able to, and it's quite narrow as well. You will not be able to readily find it out. And even if you find it out, you will not be able to, the moment you try to puncture the needle, the trachea collapses at that point, and the tracheal lumen will collapse, and directly you will be puncturing the anterior and the posterior wall, and you might be entering into the esophagus or even into the cervical rib, the cervical vertebra. So I wouldn't suggest for anybody, if you're not experienced in a needle cricothyrotomy, never ever use a stab or a cannula cricothyrotomy in children. So the best thing is to use a surgical tracheostomy. A qualified, experienced surgical ENT surgeon will know that when the child is unstable, you should never ever use a vertical tracheostomy and go for a low or a mid tracheostomy. If the child is unstable, always go for an upper horizontal tracheostomy, right at the space between the cricothyroid membrane, the cricord and the first tracheal ring. And never do a vertical tracheotomy at that point, because that is the dictum. You should never injure the first tracheal ring, whatever you do. You can do a horizontal tracheostomy at that particular point, tracheotomy at that point, and then never try to squeeze your tube over that. Always pass a bougie, and then you try to pass the tube over the bougie rather than pushing the tube or the tracheostomy tube to either the vertical or the horizontal tracheotomy that you make in these children. This is a representation of how you do a cannula cricothyrotomy in an adult. Look at the angle. You need this sort of an angle to enter into the cricothyroid, even if you identify the cricothyroid. Now, what happens is that if with the cannula, if you encounter even the slightest of obstruction, either it could be because of the tracheal cartilage or the tissue by itself, the cannula will roll over the needle, and the needle would have entered the tracheal lumen, and you might be able to aspirate air, but your cannula will still be outside, and you will never be able to, because it has rolled and it got damaged, you'll not be able to push the cannula inside into the tracheal space. Now, what happens with that? You will have to remove it. When you remove it, what happens many a times, it will start bleeding in the trachea, and then you will lose the airway. So never ever try to do, especially in children, it's a very compromised airway, never try to do that. So you'll never be able to get this particular angle to do a cricothyrotomy in children. This is almost a vertical angle that you get. And then you see, look at the very narrow cricothyroid membrane that you get. So never ever try to do a stab or a cannula cricothyrotomy in children. If possible, if you're experienced with your non-dominant hand, you will have to pull and stabilize the trachea and then do a needle cricothyrotomy and then ventilate through that. I will tell you what technique I use normally in these scenarios. Now, what I would suggest and what I practice is always a Seldinger technique. If you use even in adults, I never use a cannula technique. I use a Seldinger technique for cricothyrotomy, or even it need not be cricothyroid. You can use this technique even in the trachea for getting an airway and then oxygenating the patient. I use this particular kit almost often. I'm very happy with this sort of a needle that comes along with this, because you see, even if it's a vertical puncture, this particular needle, you with the sort of the aperture that's available, you will be able to pass the soft, straight guide wire that comes along with it. In children and in smaller children, never, even if you're using that, never ever use a J-tip guide wire, because the diameter of the J-tip guide wire, most often it is more than the diameter of the trachea. And when you pass it across, it will get curved or over the trachea, and it might come out through the glottis rather than going into the trachea. So never use a J-tip guide wire in children for a Seldinger technique. Use always a soft tip, flexible, straight guide wire. Now, if the child is a bigger child, I will dilate, and I might use this particular 4 millimeter outer diameter catheter. But the problem with this is that there is, with the introducer, there is a shoulder that is, you see. So when you're going through the cricothyroid, the cricothyroid in children are so small, you will find it difficult to manipulate and get this particular shoulder into the trachea. So in these scenarios, I will never do that. I will actually push just this part into the trachea. And at this end, I connect, there is a connector that comes along with this, and then I will be able to oxygenate the child. I will never try to push this one. I'll give you an example that comes here. I don't want to actually show this picture, but just to highlight, this is in a case report in a child, a 3-year-old child, where they tried to do, when they were not able to intubate, they tried to do a needle cricothyrotomy. They failed. First, a cannula cricothyrotomy, they failed miserably, and they tried to do a needle cricothyrotomy, and they failed. And then they passed a Seldinger wire, and then they tried to pass the cannula that comes along with the cricothyroid set. They couldn't do it at that particular point, and only at that particular point they called for the surgical airway. And of course, the surgeon was quite experienced, and so he did it, a horizontal and upper tracheal tracheostomy. But by the time he was able to secure the airway, the child had arrested. He was so hypoxemic, they couldn't revive this child, and the child expired. So don't try or get yourself into these sort of scenarios. Now, coming into the mid and the lower tracheal injuries. Now, that was earlier we discussed about the upper tracheal, that is the laryngotracheal injuries. Now, coming to the mid tracheal injuries, again, the most common one is the blunt trauma, either by crush injury or road traffic accidents or by deceleration injury in road traffic accident. I've had experience in getting some mischievous children who are quite heroic, and I'll give you an example after this, who again get a blunt injury of the trachea, resulting in complete transection of the trachea at the cervical level. There are possibilities of iatrogenic tracheal injuries as well in the mid-tracheal and the lower tracheal levels, either during rigid bronchoscopy or even during normal endotracheal intubation or balloon tracheoplasties or tracheostomies. Usually it is the posterior tracheal wall, which is the most pliable and unsupported area which gets injured. During the level 1, only when the posterior trachealis muscle alone is injured without any damage to the esophageal wall, they can be managed conservatively. But if the esophageal wall is also involved, you might have to do a surgical repair, and then you will have to manage the airway in these scenarios. What happens in these sort of injuries? Definitely you will get a tracheobronchial injury, but it doesn't stop with that. The patient will have injury in the associated organs as well. Like in the lung itself, the patient will have bad lung condition, and which might be contributing for the hypoxia. The patient might be having a diaphragm injury with the phrenic nerve involvement. The patient might have an injury of the vagal nerve, and then he will have a regurgitation, and the gastroparesis and regurgitation that might complicate the things. He might have had a myocardial contusion and resulting, or a vascular injury which results in hypotension and decreased contractility of the musculature and hypotension resulting. All these things will lead to a real challenging situation. So in these scenarios, they are most clinically challenging as well as technically challenging. When you talk about the cervical tracheal injuries, they might be partial or they might be complete. If they are complete, they might be either distracted and separated completely. Both the injured ends might be separated altogether. When they are partial, they might be asymptomatic or they might be mildly symptomatic. But when you have a complete transection of the trachea with the distracted ends and separated ends, the patient might be in severe respiratory distress. And you have a distracted, a severed trachea in the cervical, in the neck, and they are being separated. And it's a very typical and unique clinical picture. You will have surgical emphysema of the neck. You will see a swelling in the anterior aspect of the neck, which bulges out when the patient expires, and then it gets drawn in when the patient inspires. But still the patient will be able to maintain a spontaneous ventilation. So before you try to address this particular type of injury and airway, please study the CT scan images. Very important, because then you will realize whether it is a partial injury or a complete injury with distraction and separation. And then you will be able to identify for yourself what is and how much for length it has distracted. And what is the size? This is a very important aspect. What is the size of the false lumen that is available for you? Because you, at this particular point, if you try awake fiber optic intubation and you're trying to put in a microlaryngeal tube across that, you should know what is the size of the false lumen, because you're trying to, at this particular point, for a length which can be anything between 2 centimeters to 4 centimeters, you are in no man's area, an absolute wilderness. There are no landmarks for you. You see only mangled tissues and a tortuous path where you'll be able to pass your fiber optic bronchoscope, but you will not be able to see. You're looking for the distal end of the trachea, and you're trying to pass the bronchoscope through that and then see the trachea and then pass the laryngoscope. So you have two ways of securing. Either if you're confident enough and the child or the adult, even the adult patient is cooperative and is breathing spontaneously and then maintaining the saturation with your bronchoscope at that area, you can do that. Never ever try to intubate such a patient with a tracheal laryngeal trauma with a laryngoscope and a normal endotracheal intubation. I'll show you what has happened in that scenarios. If you're not confident, ask for a surgical exposure. This is one particular point which I think many of you might still be using, that those who are using fiber optic scope. When you're using an awake fiber optic scope, I don't spray the local anesthetic through this port. I always put an epidural catheter through that, and then the epidural catheter will be emerging through the other end, and then I push the local anesthetic through the epidural catheter, because it gives me a spray. And then it gives me a larger area that can be anesthetized. And even when the scope is outside in the larynx, I can still pass the catheter across the glottis in the trachea, and then I can anesthetize the trachea. This boy I was talking about, an older boy, he was quite heroic, and this is a skateboard injury, and he hit his neck on some bench or something, and his trachea was severed, and it was distracted by almost close to 3 centimeters between the proximal end and the distal end. But luckily, he allowed me to do a wake fiber optic intubation. I had already put in, because I, of course, gone through the CT scan images, as I told you earlier, because this is the proximal end, and this is the serial CT scans. And then you can see that after that, there is no trachea. It's only a mangled tissue, but it's a larger area there. And then it's almost after about 3 centimeters, I could see the trachea there. And then the trachea and the carina. So I know that I have space for the fiber optic bronchoscope and the tube to be there, and still there'll be space around for the patient to breathe. And so that is why I took the chance to intubate this patient like that. Another reason why I use a smaller, this patient I intubated with the 5-size microlaryngeal tube, because I don't want to change the tube when the surgeon has opened the surgical, the injured site, and then he asked me that, oh, I cannot see the posterior wall, please change the tube to a smaller tube. Here I can use with the microlaryngeal tube, a smaller one. I can put the tube well right across the injury, and I can inflate the cuff, and I get a good seal on that. And the surgeon can manipulate the tube to both sides, and he can switcher the posterior part, and he can then switcher them. I don't have to change the tube. That is one of the reasons why I use a smaller microlaryngeal tube in these scenarios. This is one case which is not my case. This is a case report that I've taken just to tell you. This particular patient had a similar injury. It's an adult patient, but they tried to intubate this patient by a direct laryngoscopy and an endotracheal tube. They were not able to pass beyond because his trachea had separated. They never realized, I think they did, I don't know whether they had gone through the CT images or not, but they thought that they will be able to intubate, but they couldn't intubate. It started bleeding from that area. They lost the airway and the patient arrested. They had to call for a surgical airway at that particular point, and the surgeon, he opened the whole area with local anesthetic. The patient is already arrested. And then he could find the distal, and then he intubated the distal. And luckily, in this case report, they were able to revive this patient. So that's about the cervical trachea. It's quite tricky and it's quite challenging as well. Now coming to the intrathoracic trachea. Intrathoracic trachea, I would tell you that is the most technically challenging and clinically challenging for the one single reason that you don't have a surgical option if you fail to secure the airway. So you should be very confident when you're trying to deal with an intrathoracic tracheal rupture, especially in children. In addition to that, there will be definitely associated lung injury and lung contusion, myocardial contusion, injury to the adjacent neural and vascular structures. Now, in this scenario, there will be these patients usually present with pneumomediastinum or pneumothorax or pneumoperitoneum sometimes with gross surgical emphysema. So that itself in the neck and the chest itself is a very grotesque thing, and then that's something which keeps you away from it. Why? And this happens more in children. It happens in the region about 2 to 3 centimeters of the primary carina. In children, the chest wall is quite compliant. Even if they sustain a crush injury, the ribs doesn't fracture. But because of the impact of the crush, their glottis, the vocal cords will go in for a spasm, and the sudden increase in the pressure inside the airway will lead to a sudden increase in the airway pressure and leads to a rupture of the airway. And this rupture usually happens in the area about 2 to 3 centimeters around the primary carina. I'll give you an example of this. So there are 2 ways of addressing this. If you're confident enough, you can go for, and if the child survives and the child or the patient is stable enough, you can go for a 1 lung ventilation, lung isolation for surgical exposure and also for maintaining the ventilation during the surgery. If not, for surgical exposure and an approach and for maintaining, you will have to use an extracorporeal circulatory support, either ECMO or cardiopulmonary bypass in these patients. When you decide about 1 lung ventilation, you don't have much option in children, especially pediatric patients to the age of about 6 years. You'll have to use a single lumen tube, either as a endobronchial tube to one side. Of course, you need a bronchoscope for that, and your tube should allow. So if you have a 3.5 size tube, if the child is taking a 3.5 size tube, definitely you'll be able to use the smallest bronchoscope with the suction port available. Or if you have a smaller one, about 2.5 or 3 size tube, you will not be able to use a bronchoscope which has got a suction port. You will have to use a 1.8 mm scope, which doesn't usually come with a suction port. So it's quite difficult to manage these sort of airways. Either use it as an endobronchial tube or position the tube with the trachea itself and use a bronchial blocker. There are different types of bronchial blockers. Now, earlier we didn't have all these bronchial blockers and we were using only the Fogarty catheter for them. But now a couple of bronchial blockers are available for use right from the infants and to the older children. But from 6 to 8 years, you have the option of using a univent tube, which is a 3.5 size tube that you can use. But if the child is older, more than 8 years, you can use a 4.5 univent tube, or even use a 26 WVent tube. This is more a specialty now when it comes into the lower specialty airway management. If the child is more than 8 years old, and you have to satisfy all these three, more than 8 years old and more than 130 centimeters in height and more than 30 kilograms in weight, you can use a 26 size WVent tube, either the left or the right. If you're confident enough to position it with the bronchoscope, the right one, you can use that. And for children less than that, no, you cannot. Then you will have to. For 6 to 8 years or 8 years and more, you can use a univent tube. Univent tube is a tube which can be placed in the trachea, but it has got a flexible shaft which is incorporated within the tube. And then this can be withdrawn into the tube when you're intubating the patient. And once the tube is in the mid-trachea, this can be pushed out of the tube. It has got an angled end, and with the bronchoscope in the lumen, you can manipulate it to go into the right or the left and then inflate the cuff. And then you will get an occlusion of that particular bronchus which you want to block. Now, Mararo tube, I have not used it. I will never use it as well because it's not been approved by the FDA. And I think it's only available in in Italy. The problem with that is it doesn't have a cuff for isolation. It looks like two tubes which are fused together. The problem is that if it's a smaller tubes like 2.5 or 3 size tubes which are fused together, you'll not be able to pass a bronchoscope through that. But if you have a larger one, a 3.5 or a 4 size tube, of course, then you'll be able to pass a bronchoscope and then position it. But given a chance or a choice, I will never use it. Now, we use a lot of bronchial blockers in these scenarios. The most common one is the ARNT blocker that we use and the Fogarty catheter. The problem with the ARNT blocker is that it has got a snare at the tip, and then you need a bronchoscope to railroad the snare and then position the ARNT blocker in whichever bronchus that you need. And then you'll have to remove the scope and then inflate the cuff. The ARNT blocker can be used coaxially through the tube, or it can be positioned parallelly outside the tube. So that is one of the way of getting one lung ventilation and then lung isolation in children. The other bronchial blockers that's available is the uniblocker, which is now being made by the LMA company, the Teriflex, as well as the Fuji. Here, you don't require, this doesn't have a snare, and then you don't require a snare to railroad it, but it has got an angled end. So you can pass it either through the tube or parallel to the tube, and then you can manipulate, with the bronchoscope inside the tube, you can manipulate this end into one of the bronchus and then inflate the cuff and then occur, and then you can get a lung isolation. This is one of the endobronchial blockers that we use quite often. This is known as EC blocker. It has got 2 blocking balloons. This requires this. You'll be able to use this only if you're using a endotracheal tube of 7.5 size or more. So an older child or an adult, you can use it. You need a bronchoscope for positioning this one. And this has to straddle across the carina. And so you have one bulb on each side of the bronchus, on the right side or the left side. And whichever bronchus you want to block, you can inflate and then you can block that particular bronchus. This is the Fogarty catheter. It's actually a vascular catheter. And then this is one of the things which we're using earlier. Now also I use quite a lot of Fogarty catheters for endobronchial blocking. I've discussed a couple of interesting case scenarios, which is a specialty. It's in the lower tracheal, which is one is an acute tracheal bronchial injury. In a 3-year-old child, the injury was a crush injury between the child. The child was caught between a reversing car and a wall. Don't get surprised by looking at the type of the injury. There is no point in having any type of technological advancement unless otherwise you know to use it or you really use it. I'm talking about the reverse camera. This particular child was born to the primary hospital with severe surgical emphysema and a low saturation, even with oxygen, 76%. They did the investigations, ultrasound examination, chest X-ray, found bilateral pneumothorax, and they put the bilateral chest tubes and then inserted an underwater seal and then connected to the next section, drained a lot of blood and air. Of course, the saturation improved to 90%. And then the protocol, of course, calls for a CT scan. And so in the primary hospitals, they took the patient for a CT scan, but the child was so irritable, so they had to be intubated. The moment they intubated the child, the saturation fell from 90% to 84%, even with an FiO2 1. And it never improved. And so because the child was quite unstable and the saturation was not improving, of course, they had to refer the patient to our hospital, the tertiary hospital, and we received this patient also with the same saturation. The moment we reached there, we saw that the patient was saturating quite low with an FiO2 1 and mechanically ventilated. And then we saw that with each ventilation, there were quite a lot of leak that was happening in the suction apparatus and the drainage the system. The first thing that we did was that we stopped the negative suction. This is one mistake that almost everybody makes. Even if you put a double lumen tube, what you call chest tubes, and then you connect to an underwater seal, once the blood and things have been drained, and when the patient is breathing spontaneously, and especially when you're intubating and ventilating the patient, please remove the suction from the chest drains, because air, it takes the path of the least resistance. So if you have a larger bronchus which is being ruptured, and it has got a direct communication with the either pleural cavity or to the mediastinum and the pleural cavity and to the outer atmosphere through the chest tube, and with the suction catheter, definitely all the air that you ventilate or the patient takes goes through that rather than going into the lungs, and that is responsible for the hypoxia that you see in these patients. The moment we stopped, the patient's saturation improved to about 92%. It's must that you should take a chest X-ray, because you will miss many things. Though we took a chest X-ray, and then we saw that the patient had the endotracheal tube, which was quite low. And then the CT scan, which was taken from that place itself, showed that, I don't know whether you saw that, it was a sort of a trident trachea, a lot of contusion and collapse of the lung. It'll come later now. You can see that. The trachea, when it comes, it was ruptured right at the carina. And you can see that it was ruptured right at the carina. We took the patient immediately to the theater. We did the scopy, and then we saw that that's the left bronchus, that's the right bronchus. The trachea was split at the carina. It's a 3-year-old boy. It was split at the carina. Part of the carina is the left bronchus. Part of the carina is with the left bronchus. And you see the larger size. So most of the ventilation was happening through this into that outer atmosphere and being sucked out. Now, once the diagnosis was made, we decided to go ahead with the surgery in this particular patient. And we made a plan A that we'll go ahead with the surgery with one lung ventilation. We have to check for about 10 minutes, we'll check with one lung ventilation. If it maintains saturation, we'll go with one lung ventilation. If it doesn't maintain saturation for about 10 minutes, then we'll go for a surgical repair with a veno-venous ECMO. That was the plan that we made. Now, what is the technique? The child came like this. You see the patient's endotracheal tube was almost at the point where the trachea had ruptured. Now, we just put the tube into the mid-trachea, and then I just wanted, because I saw all the CT scans, I know the right lung is also contused, the left is also contused. I now want to know which lung would tolerate one lung ventilation. And at the same time, I will get an airtight seal. So with the same tube, I passed the bronchoscope and pushed the tube into the right side. And when I could get an airtight seal, I saw that saturation from 94, it fell to 80%. So that means the tube had to push too much inside, and the cuff would have blocked the upper lobe. So this lung is not suitable for one lung ventilation. And so then I passed the tube to the left side because it was a bigger tube. The tube wouldn't go into the left side because it's a smaller bronchus, but I could get an airtight seal with the cuff slightly snugged across this. And then the saturation dropped only to 90%. So I knew that I will be able to maintain a one lung ventilation with this, but I will have to again utilize the right lung for ventilation. So we went and we checked what size of tube. We measured the left bronchus with the CT scan. And so the tube size that he would take was an outer OD with a maximum of about 6 millimeters. That is a 4-size tube. So what we decided that I need to utilize the right lung. So I have to utilize the right lung for apneic ventilation with oxygenation. So I utilized a suction catheter, a 6-French suction catheter. You know that a 6-French suction catheter cannot be induced because it's quite flexible and pliable. So I used a normal J-tip CVC guide wire to make it rigid. And then I could get an angled end. Because of the J-tip, I could get an angled end as well. So I intubated the trachea first with this suction catheter, and then the 4-size tube, and then the bronchoscope to the tube. And then I manipulated the suction catheter into the right bronchus, placed it at the right lower lobe, removed the suction catheter, and then I started oxygenating with about 10 liters per minute, because you need a larger airflow, oxygen flow through that, because most of the air will go through this opening. And for some amount of oxygenation to happen, you should have a larger airflow to happen. And when that was attained, then I went in through that and positioned the 4-size tube in the left side, close to the secondary carina. Now, that is an operative picture that shows the suction catheter that it was not interfering with the surgery at all. And then we finished the surgery, and then that's a repaired carina, and that was the carina before. Now, that was the bronchoscopy I did just before discharging the patient. The healing process in children is so good. You wouldn't even feel that this is a damaged or injured carina. It was looking quite normal. This is in about 8 days' time. The child was discharged in 9 days, and 2 weeks after the discharge, there's a X-ray of the child. Now, that's the second child. This child was even a severe case. We got the child about 1.5 months after the injury, because the child had multiple injuries, liver lacerations, multiple injuries. So she underwent many surgeries before she was referred to us. And by the time she was referred to us, she had a distal left bronchial injury, which is complete transection. The whole area had healed by granulation tissue. So the lung was fully collapsed in that area. And then we made the diagnosis, and then we made a plan A that we'll go ahead with surgery, and then with 1 lung ventilation. And for that 1 lung ventilation, the surgeons felt that because the distal end of the trachea, the proximal trachea, which had almost got displaced or retracted into the upper mediastinum, was just below the aortic arch. So even when the surgeon goes through the left thoracotomy, he will find it very difficult to go to and find out where the distal end of the proximal tracheal stump is. So we suggested that we will show you the proximal end with the bronchoscope light in the stump. So this is the technique that we use. We position the bronchoscope in the bronchial stump, and all what the surgeon had to do is that go towards that light. And so he was able to reach the bronchial stump. And for that, we had to do a lot of manipulation for the how we manage this case. So the child had a tube inside because he was still getting ventilated. So we put a Fogarty catheter in this on the left side, because this is the stump which is blocked. With the bronchoscope, we placed the Fogarty catheter in the left bronchus. And I used a different type of tube. This is a tapered cuff tube. And then I made some manipulations here, because I enlarged the Murphy cuff, and I made another Murphy eye, enlarged this Murphy eye, made another Murphy eye with very little tube remaining in the distal to this cuff. And I intubated this trachea with this tube. Now I have a Fogarty catheter, which is outside the tube, which is in the left main bronchus, and the trachea has got this particular tube. And I passed the bronchoscope and positioned the bronchoscope here, and I was lighting the bronchoscope for the surgeon to see and come on towards that. Once the surgeon reaches here, he should not be opening it. The moment he opens, what will happen is that because the tube is here, I will lose all the ventilation, first of all. Second thing, all the blood and the debris will get into the only working lung, that's the right lung. So before he opens, what I have to do is that I have to inflate the Fogarty catheter. I have to remove the bronchoscope from there, inflate the Fogarty catheter, and then I have to pass the bronchoscope to the right side and position the tube onto the right side. Because it is a flexi tube, I showed a taper cuff tube, I will be able to position it, occlude this area because of the typical design of the cuff. At the same time, I will be able to position the tip of the tube, well ventilating the right upper lobe. So this is the The Fogarty catheter that was in the left lower lobe, we inflated it. That's a Fogarty catheter which was inflated. And after that, I passed the tube onto the right side. This is the Murphy eye which had enlarged, and that's the right upper lobe. We positioned properly, we could see the right upper lobe, and we were able to ventilate at the same time, get a good seal as well. Now the surgery was done, and then the child survived, but we had a lot of problems in the post-operative period because the whole trachea at this point was crushed. And so the child had a severe bronchomalacia, and the child, we had to put in a bronchial stent in this patient. And in fact, today we took out, because it's a biodegradable stent, the first stent got degraded. And today, in fact, we put a new stent across this again after 3-4 months. Now, this is the repaired trachea. Now you can see that that was injured site. It was close to the secondary carina, very close to the secondary carina. All right, so that's about it. Now let's look at what are some of the take-home points or the points to remember. The last couple of slides for this. The management of pediatric airway is quite challenging, and never take it lightly. As I made the statement earlier, it's improper assessment and planning and execution which results in a catastrophe. So always assess the patient properly from the history, physical examination, and all the radiological investigations, especially the CT scan, all by yourself. Be aware of the limitations that the system in which you are working, and also about the skills that you have and the person that you're dealing with, and to help before you make any plans for management. So be aware of your limitations and the system's limitations. Never ever put blindly a supraglottic airway if you're suspecting a laryngotracheal injury. In fact, most of the laryngotracheal injuries, supraglottic airway is contraindicated. Now, if you feel and if you're in doubt that the child has a compromised airway, don't do anything that stops the spontaneous breathing of the patient. Always have an experienced pediatric ENT surgeon on site before you try to attempt the airway interventions in pediatric patients. And also have one or more dependable, experienced anesthesia colleagues for you to help during these procedures. Always have a plan A, plan B, and a plan C, depending upon all the assessment that you have made. And then you should be very well aware of what are the resources that you have at hand. It's not enough that you have an algorithm that is hung up by the side of your anesthesia machine. Now, call for help before it's too late, because all of you know that the children, they have a very low reserve for oxygenation. Never ever try to do a cannula or a needle, a cannula or a stab cricothyrotomy in children, and do a needle cricothyrotomy only if you're experienced, especially in pediatric patients. If you have an indirect video laryngoscopy, use it as a first choice. Of course, it's used as a learning curve. So if you have not used it, try to practice it in normal children and not try to use it in an emergency situation for the first time. Fiber optic bronchoscope assisted intubation, maybe that's a magic wand, but you know that blood in its way, a fiber optic bronchoscope becomes absolutely useless. And the usage of a fiber optic bronchoscope has a longer learning curve. So try to acquire the skill during the peacetime and not during the wartime. I always do an insufflation of the oxygen near to the larynx when I'm anticipating an extended trials of intubation. Always anticipate injury to the adjacent structures, and that might be the one which will lead to a compromise in the oxygenation of the patients, and be aware of it. Avoid negative suctioning, because the child would have been having a negative suction when it's come to the theater, but at the time you're intubating, at least try to remove the suction and leave it open to the atmosphere. One lung ventilation children can be trickier, so please try to get expert help. Try to always use the potential of apneic oxygenation in the non-ventilated lung when you're using one lung ventilation. In adult patients, you know that when there is a problem with oxygenation, you do CPAP, and then the initial PEEP, and then the CPAP in the non-ventilated lung, which is not possible in children. So try to plan a procedure where you will be able to use the potential of apneic oxygenation in the non-ventilated lung. And be aware in the system that you're working in and resources that you're working with doesn't allow you, and the patient's conditions permit to be referred to in a hospital, please refer this patient to an appropriate center. Thank you very much for the patient listening.
Thank you, Dr. Suresh. That was really a wonderful talk with a lot of practical tips from your experience. We really enjoyed the clinical scenarios you explained with its detailed slides. Very informative talk and really benefited us. Now, Dr. Biril, you can take over the questions from chat box, if any.
Before going, thank you, sir. And before
Dr.
going,
Thank you very
chat,
much.
I got some doubts. First, I will ask my doubt.
Please.
Sir, you told about putting a Fogarty to separate the lungs. Even
Yes.
I have tried it. A couple of the cases I have done, but how we can direct to the particular bronchus while we are putting a Fogarty? Is there any technique for that?
Yes, there are some techniques for it. Two things. If the patient is already having a tube inside, all right, then you will have to use a coaxial technique. And then for that, you will have to have, you saw the devices that we're using for coaxial technique. You should have those devices if you're using a coaxial technique. Then you can position with the bronchoscope, you can direct the tube into whichever bronchus you want. And then through the tube, you can put the Fogarty catheter into the tube and then withdraw the tube into the trachea and leave the Fogarty catheter there. All right, either into the right or the left. But if you don't have any of those contraptions that will allow you for a coaxial use, then you will have to use it outside the endotracheal tube. Then in that case, one of the best blockers that can be used is a Fogarty catheter. Never take the stillet outside from the Fogarty catheter when you're using. With the stillet inside, make an angle at the tip, because the stillet of the Fogarty catheter is a catheter with a very high tensile strength. You make an angle, that angle will never go off. You will not be able to get rid of that angle. So if you make an angle at the tip, you can intubate the trachea with the Fogarty catheter itself first, and then place another tube in the trachea, and put a bronchoscope into the tube, and then you manipulate your Fogarty catheter with the angled tip, either to go into the left or to the right. And once it is in position, you remove the stillet from inside, and then you can inflate the cuff. So this is the technique that I use for positioning and there's another point as well. If you're trying to inflate the Fogarty catheter before you deflate the lung, when the surgeon tries manipulating the lung, and if the lung is inflated, and if you already inflated your Fogarty catheter, this Fogarty catheter is not going to remain in the bronchus. It will just get expelled from the bronchus into the trachea. So what you have to do is that you have to put in a suction, if possible, into the the trachea, or put a bronchoscope, a suction into the bronchus, and ask the surgeon to squeeze the lung properly. And if it is not a lung abscess or anything, you can, in fact, squeeze the lung, deflate the lung before you inflate the Fogarty catheter. Once the lung is deflated completely, and then you inflate the Fogarty catheter, nobody can displace that Fogarty catheter from there, whatever the surgeon do on that. Okay.
And sir, what's your opinion about the supraglottic device in neonates?
You see, the smallest laryngeal, the combo tube that is available will not allow you to put into the supraglottic area that's what you call as a tracheobronchial laryngotracheal device, or like laryngoesophageal device or laryngotracheal device. That doesn't help you. The only thing that you can use is the smallest LMA that you can use. There are scenarios where they have used size 1 LMA or size 0 LMA as well. I think there's a size 0 LMA that's available that can be used in children, in neonates, in fact.
And what is your take?
Pardon me?
What is your opinion, sir? What's your experience on that?
You see, I've used a size 1. I have not used a size 0. I've used a size 1, not in an immediately born neonate. I've used, I think, in about 3 weeks old child. I think I've used a size 1 LMA.
And it is safe to use?
It's safe.
Okay, thank you, sir. So now we'll move on to our chat box questions. We have one question from Dr. Sanish from Trivandrum. in a good institution, how long will it take to institute ECMO in dire pediatric airway emergency? When do you go for it?
You see, there are a couple of points to it. You see, when what we do is that when we anticipate, because we'll be quite confident if we decide when our plan A is one lung ventilation, go ahead. We'll be quite confident about it before we. So if you're not confident about plan A, what we do is that we cannulate these patients' femoral vein and also the IJV with an 18 French cannula, and then we leave it in place even before we try for the airway intervention. If at all we fail, all what it takes, because by the time I cannulate the femoral vein and somebody else cannulates the IJV, my perfusionist would have been ready with my ECMO machine, the ECMO circuit. So it takes, I would say it takes about less than 5 minutes to institute an ECMO.
Okay, sir, we don't have any more chat box questions. So now our seniors can ask the questions if they want. The participants can unmute by themselves if they want. Girish sir.
It's an excellent lecture and very beautiful. And though earlier we are thinking only 30-minute lecture, people give 1 hour lecture also very nicely and very interesting. And nobody. There was a
Thank you very much.
Dr.
I was more worried whether somebody will sit and listen the whole thing.
Dr. S. Ramesh sent a personal medicine, excellent lecture. He has sent just now that he has sent in between. He has sent very excellent lecture. He is there. Any comment, Ramesh sir? Yes, Ramesh is there. He has sent a message. And any senior?
If you don't have any more, thank you very much for the patient listening, and thank you very much for giving me this opportunity to talk to you all. And I'm seeing many new faces, in fact, almost after about maybe 10, 20 years or something like that. And many new faces as well. But most of them, they are not seen, only the names.